Hello, friends. Welcome to yet another session of Doctutorials and RRM presenting for INI SS. So this session today is going to be a revision of your, previous papers. I think this is the 2022 paper or the 23 paper. I'm not sure which. It's a collection of questions. So, some of them might have already been discussed, but generally I find the older papers, the question starts coming again. So that is what we are going to discuss today. And depending on how we manage to find time in the next couple of days, I might be having some other high yield topics as well. And we'll see if we can do on tomorrow and day after as well. I'll just update the timings tomorrow. So without much ado, let's get on with the topic for today. So yeah, so this is one common question that we get, something based on what you can say as molecular genetics and the types of cancers and all this. In this, one of the common cancers that is coming up today is going to be endometrial cancer. Now, endometrial cancer, recently there has been a change in the staging as well, based on the pole mutation, based on the, not actually on the pole mutation, is based on the grade of the tumor and the type of the tumor that we have. I will have a discussion on that in the update class. So for as far as this particular thing is concerned, what we have to remember is, just like in breast cancer, we have the four subtypes as luminal A, luminal B. Then we have the the HER2 enriched type, and also we have the triple negative or the basal types. Similarly, in endometrial cancer, we now have a staging based, not the staging. We have now a molecular classification. So in this, the question here is, which is the one which has got a good prognosis? The answer is, of course, the pole mutated type. So pole mutated type. So the sequencing goes something like this, and this has not changed from 2022 till now. The same thing is applicable even in the current NCCN guidelines of 2024 as well. So if you look at it, what we do whenever we have an endometrioid cancer is basically the first thing you do is a pole sequencing. If the pole is mutated, then straight away you put it into the pole hypermutated subtype, and this is around 10% of all endometrial cancers that we have. This is the type which has got the best prognosis. Current strategies include de-escalation. Just like we have, for example, in head and neck cancers, we were discussing about the HPV positive oropharyngeal squamous cell carcinoma, where we talk about the de-escalation strategies, either in terms of avoiding chemotherapy or reduction of chemotherapy or reduction of dosage of radiation. All these are techniques that we discuss in oropharyngeal squamous cell carcinoma, HPV positive. In fact, the nodal staging is also different for them. The same way for a pole positive endometrial cancer, currently de-escalation strategies are being worked out. We do not have any formal guidelines, but if the question comes something based on pole and what will be the therapy, generally you can mark the least possible thing. Suppose observation is an option, yes, that will be the option in adjuvant therapy. That is the way the questions might be asked. So if you have a patient who has, let us say, a PT1B tumor, and otherwise it is grade 2, all this is there, but if they mention in addition pole mutation is going to be there, for example, normally this T1B grade 2 will be something that will go for adjuvant RT. But here is something where if you have the pole mutation, generally the answer the examiner might expect is something like observation rather than going in for any adjuvant therapy. Now, the next thing that you check for is, of course, going to be the MMR protein biochemistry. So if you have the MMR protein, now remember, we talked about this when we were having the class on stomach and esophagus as well. So MMR is detected by the IHC technique. And when you talk about MSI, this is done by the NGS for the genes. The next generation sequencing of the genes will be used. Either one is fine. So whenever you talk about MSI high or you talk about DMMR, both of them mean the same thing. Okay, so you have MSI high or you have DMMR, which means deficiency in MMR. So either of the two essentially means the same. So yes or no. So if you have that, then you call it as basically when the expression of MMR is lost. So then you have the MSI high type. So then you have the next one. If both of this, if pole is not there, and then if there is no pole mutation and the MSI is also not high, then you look at, which means there is a retained expression of the MMR genes. The mismatch repair genes are intact. Remember, this is a distinction that we have to make. When we talk about PMMR or proficient MMR, proficient means it is expressed normally. So when there is a normal expression of the MMR genes, this means it is likely to be microsatellite stable or MSI low. Either of the two types is going to be there. And this in turn makes it a poorer prognosis. MSI high is the goodest type. MSI low or MS stable is going to be the poorest prognosis overall. So then you look for P53. So when you have P53, if there is going to be a, what you can call as, sorry, when you have the apparent or mutant pattern of P53, then you call it as copy number high. So whenever there is a P53 mutation, then you call it as a copy number high. So now this copy number high, 25% of patients had the copy number high, and this is the one which had the worst prognosis. P53 mutant type, usually they were grade 3, serious type of carcinomas were common. This one was the one which had the worst prognosis among all the TCGA subtypes. Now, this is known as the TCGA molecular subtypes. What do you mean by TCGA? The Cancer Genome Atlas. Remember, we had a similar staging as far as molecular types of gastric cancer were concerned. So the same way you have the gastric cancer staging, the TCGA staging for gastric cancer, similarly you have in endometrial cancer. In endometrial cancer, actually it is very well established. So one is the pole type. The second one you look for is the MSI high, which essentially means MMR deficient types based on IHC, and genetic studies for NGS, which you look for the MSI thing. So either of these two established, here is where you will get the Lynch-like phenomenon. And remember, in Lynch syndrome, when we are talking about particularly in terms of endometrial cancer, the most common mutation you will find is in the MLH1 gene. Now in colorectal cancer overall, and generally if they ask you the MSH2, this is the mismatch repair gene which will be most commonly involved. The most commonly involved gene is going to be your MSH2. Then if you talk about endometrial cancer like phenotype in a Lynch syndrome, there MLH1. So I basically remember it as LH. LH stands for, if any of you is a hostelite, then you will remember LH as ladies hostel. So ladies get endometrial cancer. Some quirks, the way we can remember, because you get lot of names and things that come. So that is the way I remember. So LH stands for ladies hostel. So essentially MLH1 is going to be a ladies type of cancer, which is going to be endometrioid cancer. So that is what you will get as the most common type of mutation in Lynch syndrome associated with endometrial cancer. But overall most common, if you look at the overall most common mutation as far as Lynch is concerned, then the answer is going to be your MSH2 gene, where CRC is the most common cancer. So the order of mutations or order of malignancies, CRC is the number one cancer. The second one is going to be your endometrioid cancers. Okay, so the second one is going to be your endometrioid cancer as far as Lynch syndrome is concerned. So prognosis wise, if you look at it, when you have the pole mutation, it has the best prognosis. P53 has the worst prognosis. Next best to pole is actually the MSI high or the MMR deficient type, where you will have MLS mutations most commonly. Then there is another variant called as the CTNNB variant or the beta catenin variant, where it is a copy number low. So you basically, it's a triple negative kind of phenotype where you do not have any of the mutations. You do not have pole, you do not have MSI, you do not have P53, nothing is there, then you call it as a copy number low. So copy number high is basically P53. When there is a mutation, you will have a lot of aneuploidy and all that happening. Whereas in a copy number low, when you have it, that is the most common type overall. You have the beta catenin mutation. You have the beta catenin mutations that will happen commonly in this particular subtype. So serous, the top comes, then it is related to your P53. So when you talk about MSI high, then you will have the Lynch syndrome like phenotype, which will be very commonly found. Pole will have the best low-grade tumors, usually that will be found. And copy number high is something where you will have the P53 mutation and the grade 3 or the serous types. Copy number low will be the beta catenin type. So this is a question that you can expect as far as endometrial cancer is going to be concerned. I'll try to discuss the endometrial cancer staging also, which is likely to come. Cervix, endometrium are all recent stagings that have come, so they might have a question from that. I'll try to discuss it in the next session that we have. So cervical cancer, in a patient with cervical cancer, there's a question on cervical cancer. You have a patient who has PAP, which is showing ascus. So what will be the next line of management for this particular patient? Is it going to be colposcopy, follow-up cytology, cone biopsy, or HPV DNA testing? This is not for cervical cancer, basically for PAP smear. So you do a PAP smear. PAP smear shows ascus. What is going to be the next step in management? Here the answer is going to be, of course, your HPV DNA testing. Now there is a trial called as ALTS trial. Okay, so ALTS trial, which was basically a triad system where screening was done for patients with ASCUS. So ASCUS stands for atypical squamous cells of unknown significance. So just like you have FLUS, okay, ATP of unknown, AUS bar FLUS in thyroid. You may remember this in the Bethesda classification as Bethesda 3. This is where you will apply the molecular staging. I tend to digress a little bit and give you some additional points just for you to remember and correlate. So just like you have FLUS and AUS as far as Bethesda molecular type of stage 3 is concerned in thyroid. Similarly, you have something called as ASCUS, which basically stands for atypical squamous cells of unknown significance. Now, this is the most common abnormality which will be seen in pap smear. So you have pap smear testing, the Bethesda reporting is going to be there, in which multiple types are going to be there. So here again, remember, you have grade 1, which will be labeled as LCIL. So low grade squamous intraepithelial lesion. So low grade squamous intraepithelial lesion is LCIL, and this includes only the grade 1 pap smear abnormalities. Whenever you have your grade 2 or grade 3, both of them will be grouped together as HCIL. Now, when a patient is having an LCIL diagnosis, you can even observe the patient, follow the patient serially. All this you can do. On the other hand, whenever you have grade 2 or grade 3, which means either of these, this is one fallacy of the Bethesda system as far as your, smear system for cervical cancer is concerned. So HCIL basically includes a lot of grade 2 lesions as well, where it may be a little bit of over treatment, but that is the current system, so we cannot really do anything about it. So whenever we have a HCIL lesion, the management will be at least to do a bone biopsy or a hysterectomy. Okay, bone biopsy or a hysterectomy will be the way the things will go if at all you have a patient who has got a HCIL lesion. Okay, now coming back to ASCUS. ASCUS is something like an indeterminate thing where we do not know what to do. So in this scenario, what you do is you screen for HPV. And if HPV is not present, or if only the low risk HPV types are going to be there, then you put the patient back on routine screening. This was the trial, ALTS trial. This was the finding of the ALTS trial. On the other hand, if there is high risk HPV, that is when you will go for colposcopy and further for bone biopsy or hysterectomy. Okay, so based on the colpo findings, then you will go for further surgical therapy or management. On the other hand, if you do not find any major lesion, I mean, any major of the high risk types. So what are the high risk types? So HPV 16 and 18. Both of these account for 70% of all squamous cell carcinoma of the cervix. And this is the reason why we use the vaccines Gardasil. Currently, Cervarix is not available. So currently, that is why Gardasil is the preferred vaccine. So Gardasil generally means Gardasil 4. So this includes type 6 and 11, which will be important for the benign warts that cause, and of course the 16 and 18, which are important for 70 to 70% of squamous cell carcinomas in the world today. So at the time that the vaccine was made. And other than this, of course, you have the Gardasil 9 also. So other than these 4 types, you will have the 31, 33, then I think you have 45, 51 and 58. I think these are the subtypes. I'm not sure of the exact numbers. You can look it up. So these are the high risk types. So overall, it will be 2 low risk or benign types and 7 high risk types, from which the protection will be provided by your Gardasil 9. So Gardasil 9 gives protection against 9 types totally, of which 7 are the types which are associated with cervical cancer. Now, when you take up Gardasil 9 versus G4, which is the preferred vaccine, overall it will seem like, G9 is preferred because it gives protection over a lot of different strains. But currently, there is no evidence to show that one is superior to the other. Gardasil 9 is equal to Gardasil 7, Gardasil 4, maybe because most of the cancer is caused by HPV 16 and 18. So currently there is no difference between G4 and G9. In the future, this is likely to change because as more and more vaccines, in fact, what is the Indian version of the vaccine that we have gotten? So we have gotten an Indian version of the vaccine, which is already there. So that one is being produced by Serum Institute. By India, it is being produced by the Serum Institute, which again protects against the 16 and 18 types, and this has got the same recommendation. So we have got the Indian cervical vaccine, cervical cancer vaccine is already available. So this being the case, that is the way we'll have to manage a patient. So in essence, whenever we have got a what you can say, as a lady who gets this ascus abnormality. Whenever we have got a lady who has got the ascus abnormality, then the first step that you have to do is for testing for the for HPV testing. So this HPV testing, whenever we do, then we will get to know whether there is a high risk type or not. And if there is going to be a high risk type, only then you will plan for colposcopy. Otherwise, there is no need for planning for colposcopy. Otherwise, there is going to be no need to plan for colposcopy. Now, the Indian vaccine, the name may be asked. This is known as Sarvavac. Okay, the Indian vaccine, the name is known as Sarvavac. So that is the question that may be expected, because India has now planned for something like, Sarvavac is equivalent to Gardasil. Sarvavac is now equivalent to Gardasil. The cost is slightly lower. In fact, they are planning to introduce this as part of the national immunization program. That is one thing, but it's still not clear how we are planning to do it. Currently, it is available only in the government sector, and some, they have just started the sales, but they may ask you the name of the vaccine, that is Sarvavac. Okay, so I tend to digress a little bit, as I already told you, but these are all related questions that may come. So that is why the same presentation, if it is made, still it will be, slightly different from what we have addressed or discussed previously. Okay, so now going on to the next question here. Yeah. So post-hysterectomy status for fibroid many years ago, what is going to be the cervical cancer screening program that you will advise? So is it going to be every 5-yearly HPV with the pap smear? Every 3 years you do a pap smear, or you do an annual pap smear, or no screening is required? Here the answer is, of course, no screening is required. Now, this one, the basis is, so whenever you look at the cancer screening guidelines, this is very important. So cervix cancer is something that comes up often. So you have to understand the guidelines also a little bit. For mammogram, I already told you the age you take into consideration is 40 years. Though there are, I think US Preventive Task Force will give the age as 45 years. If you take up the NICE guidelines, it will be 50. So for mammogram in general, but as far as the exam is concerned, if they do not ask any specific, kind of like USPTF or something like that is not asked, then the answer is going to be 40 years when you start initiating a mammogram. On the other hand, as far as ladies and cervical cancer is concerned, the screening starts from 21 years. The earliest stage of screening starts from 21 years. Less than 21, screening is not recommended. So from 20 to the 21 to 29, to be very specific, you do only pap smear cytology every once in 3 years. Okay, so in American Cancer Society slightly differs on the age. They start from the age of 25. So they say even from there you do a primary HPV testing. Okay, but in general, what is followed across the world is from 21 to 29 years of age, you go for cytology alone. This is because the HPV infection rates is going to be pretty high at this point of time, including the high risk states. The HPV infection rates is going to be pretty high. But then if you look at actually persistent infection, which will happen, this persistence of infection is going to be very low in this age group, and that is why it is better to start screening only from 30 years onwards. It is more economical, will lead to less of confusion, because just the presence of HPV high risk infection is not enough to cause a cervical cancer. Because a patient develops a HPV infection does not mean that they will go on to develop cervical cancer. So that is why HPV is essential. It is known as an essential carcinogen. Okay, so if you look at the carcinogenic nature, HPV high risk types are going to be essential for cervical cancer, but they are insufficient. But it is insufficient to cause cervical cancer. So just because HPV high risk subtype is going to be there, it doesn't mean cervical cancer will happen. But in the absence of HPV, it is highly unlikely that cervical cancer will happen. That is how the causation works. So you need HPV, which is an essential factor of causation, but it is not enough or not sufficient as a cause of cervical cancer. Now, so that is the reason why you will not do the HPV testing from 21 to 29, because there is going to be a high chance that it can get cleared in that age group as well. Infection rates may be higher, multiple sexual partners, experimentation, all this is more likely in that age group. So infection may get established, but at the same time, persistence may not happen. Clearance will also happen. Clearance of infection, clearance of HPV may also happen. And that is why you start screening with HPV testing every 5 years Currently the recommendation is to do only HPV testing every once in 5 years, starting from the age of 30 till the age of 64. Okay, so 30 to 64 is every 5 years once you do only the HPV testing. That is enough. Or some people say do co-testing with pap smear as well. Now, this pap smear is actually not needed because even if you find other abnormalities, provided HPV is negative, the high risk types HPV is negative, then you can actually leave it. There is no need for doing any other testing. Okay. On the other hand, if you do not have HPV testing being done, so in that case, you can do cytology alone for 5 years. Okay. So either pap smear plus HPV combination once in every 5 years, or HPV alone once in every 5 years, or if you are doing only the pap smear alone, then you have to do it once in every 3 years. And this is from the age of 30 to 64 years. And more than or equal to 65, it is enough to stop screening, provided, but there are some conditions, terms and conditions apply basically. So here, adequate prior negative testing. So what do you mean by adequate prior negative testing? 3 testing should be negative. 3 negative consecutive cytology, or 2 negative co-testing. So basically, in the last 10 years, there should be nothing positive, nothing suspicious, no ascus, no high risk lesions, nothing should be there. 3 means like, if you talk about 2 post-testing, which means 2 into 5 years, you have done it, there is nothing. Or 3 into negative cytology alone, 3 into 3, so that is 9 years. So somewhere around 9 to 10 years, you have not had anything positive happening. So if that is the case, more than 65, you can stop testing. Okay. And again, the last test should also be negative. Okay. And the most recent test within the past 5 years should be done. Again, this is important because somebody might have had, routine testing starting from the age of 30 to 40, for example, they might have done it, or 40 to 50, they might have done it, and then they might have stopped. So that doesn't mean you can stop screening, provided the last testing was within the last 5 years. If all the conditions, so testing less than or equal to 5 years, so at least 60 years at the age of 60, okay, one testing should have been done. Okay, so at the age of 60 years, one test should have been done, and 3 into 3 as far as PAP is concerned, or 2 into 5 as far as the co-testing or the HPV DNA testing is concerned. Any of this should be satisfied, then you can stop testing. That is the guideline. So any age with a total hysterectomy, again, this wording is important. So that is how an examiner will play around. Okay, that is how an examiner will play around. Okay, so what is the way that if I am setting a question, what will I ask? Patient underwent a subtotal hysterectomy, or I'll say a supracervical hysterectomy, or I'll just say subtotal hysterectomy. I will just say subtotal hysterectomy has been done for a patient. What is going to be the screening protocol? So remember, the answer is it should be a total hysterectomy. It should be a total hysterectomy, including removal of the cervix. Then no further screening is necessary. But again, look at the 2 asterisk marks here. What does it indicate? It is recommended for at least 25 years for high-grade SIN2, SIN3, or adenocarcinoma in situ, or high-grade cytology, or ASH, even if this is beyond this one. So after hysterectomy, when can you avoid screening? Only when the hysterectomy is not done for these conditions. So what are they? ASH. There is a group called as ASH. ASCUS, which is suspected high-grade cytology. Then you have your HSIL, which is essentially your, SIN2 or SIN3. When you have it, so HSIL, SIN2 or SIN3, whenever it is there, or adenocarcinoma in situ, it is known as AIS, adenocarcinoma in situ. So any of the pre-malignant kind of lesions for which hysterectomy has been done, because many of the pre-malignant lesions, you will do a simple hysterectomy. So if that is the reason why it has been done, then you have to continue screening. Okay, otherwise you can stop further screening. So if you look at the question now, so this is done for a fibroid. So post-hysterectomy. So any age where you have done a hysterectomy, complete hysterectomy has been done. And if nothing is mentioned, they have just said hysterectomy. So do you know whether it's cervical, total hysterectomy, or subtotal hysterectomy? Generally, when nothing else is given, it means it is a total hysterectomy. So these are the guidelines. So it's a very simple thing. 21 years, less than 21, nothing. 21 to 29, you do pap smear once in every 3 years. From 30 till 64, you do a HPV testing once in every 5 years, or continue the pap smear every once in 3 years. Then If the age is more than 65 years, you can stop, provided 2 into 5 or 3 into 3. One of these criteria is fulfilled. And again, the last test has been done within the last 5 years. These two criteria are satisfied, then more than 65 you can stop. That is one. Second thing, any age, whenever you have a hysterectomy which is completed for a benign cause, meaning no ASCUS, no ASC-H, no HCIL, no SIN2, no SIN3, no adenocarcinoma in situ, nothing like this is there. Again, no further screening is necessary. This is the current screening recommendation across the world. Whatever else is there across the world, this is the recommendation that will be followed, and that is something that may be adapted. So any of this may be asked. Again, I tell you, my friends, do not be hung up on last year's questions. This particular question I have not been asked, this paper has not been discussed. You look at it, usually the questions are going to come from the same areas. It is not the same questions that will come, it is almost always the same area. So look at it, understand, then you will be able to answer very well. So cervical cancer is important. The same way I'll be discussing on cervical cancer staging and endometrial cancer staging as well. Those two are going to come, right? So this is now a current thing. HIPEC, lot of questions do keep coming up on HIPEC. So any new trial that comes upon HIPEC will be one of the things that you are likely to expect. So HIPEC is effective with a survival rate of around 50% if done in which condition? Is it primary? Is it secondary? Is it suboptimal primary? Or is it interval cytoreduction? Now, whenever we talk about this term cytoreduction, these are some terms that you have to understand. So what do you mean by this primary cytoreduction? Primary cytoreduction is you go for essentially what we in the oncology or non-oncology parlance called as straight surgery. So patient comes with an ovarian mass. Okay, ovary mass is there, and plus or minus other things, deposits might be there, everything might be there. You straight away do a laparotomy, a staging laparotomy as it is called. Okay, so it is called as a staging laparotomy. Primary staging means primary cytoreductive surgery is also known as the primary staging laparotomy, where you do a complete thing. Here again, some of the things that you will need to remember are xiphisternum to pubis is going to be the incision. Then first step will be cytology. What is the first step which will be done? That will be the cytology. Secondly, you may need to remove the mass. If it is a large bulky mass, only after removing the mass you can send it for frozen section. Then usually you will proceed with the rest of the staging in the form of TAH plus contralateral salpingo-oophorectomy. So the procedure done on this particular side and removal of the mass is usually a salpingo-ovariectomy. Okay, whenever we remove an abnormal ovary, it's known as a salpingo-ovariectomy. That is the term which will be used. Oophorectomy is generally, this is something which gynecologists mention. I've not actually come across a major reference for this, but generally the term which will be used is an ovariectomy for a ovarian pathological lesion and oophorectomy for just removal of the ovaries if it is looking benign. So essentially you'll remove that side ovary and tube, send it for frozen section, and then once the report is confirmed to be malignancy, or in old age if you want to confirm the hysterectomy, you do TAH and a contralateral salpingo-oophorectomy. Then what do you do? Then you do for peritoneal biopsies. So what are the areas of peritoneum which will be taken, and what is the size? Now it is a 5 into 5 centimeters square. This is the area, 5 into 5 centimeters. Minimum the area has to be taken. Usually the pelvic peritoneum is taken completely. Pelvic peritoneum will be taken completely. If not, you have to take it from the POD and the bladder. Both of these areas, the pouch of Douglas is taken and the bladder peritoneum is taken separately. So these two should be done as far as the pelvic peritoneum is concerned. Then of course you have the paracolic peritoneum, right and left subdiaphragmatic peritoneums you will have to do. Okay, so these are all the areas from which the peritoneal biopsy size of around 5 into 5 centimeters has to be taken. Now, peritoneal cytology, again, they might ask you a question around 50 to 100 ml is the answer. If you want to stick to one answer, then the answer is going to be at least 100 ml of fluid has to be taken. Suppose there is not 100 ml of ascites or fluid is not present, then you add 100 ml of saline, instill it in the subdiaphragmatic areas also, and then you suck out so that you get a 100 ml sample. Okay, you may need to add heparin to it to make sure that the cells do not get lysed. Heparin is to prevent the clotting of the cells and the lysing of the cells in the cytology sample. So cytology, what is the amount of fluid? It's 100 into 100 ml. I'm sorry, 100 ml. And what is the size of the peritoneal resection specimen? It is 5 into 5 centimeters. Areas are entire pelvic peritoneectomy, you can say, or in some cases it may be bladder peritoneum and POD peritoneum plus paracolic, then your subdiaphragmatic. All these areas it will be done. Then of course you will have your minimum is an infracolic omentectomy. When will you stop with an infracoelic omentectomy? When it looks grossly normal. When it's a normal omentum, you'll do a infracoelic omentectomy. Otherwise, you'll do a total omentectomy. What do you mean by saying a total omentectomy? Now, this total omentectomy includes the gastric arcade. Okay, the total omentectomy includes the gastric arcade. So, if you look at the stomach, which is going to come up like this, and the colon, which is going to be like this. In between the two is where you're going to get your momentum. This entire momentum will be taken, and here the gastric arcade will be there. The arcade is removed. So whenever you're talking about a omentectomy, the arcade will be removed. Along the greater curve, the arcade is also removed whenever you're doing a. So this is going to be the arcade. So this gastric arcade will be removed when you're doing the total omentectomy. When you talk about a total omentectomy, the gastric arcade will be removed. The blood supply will be from the other areas. Okay, so the gastric arcade is usually removed whenever you're talking about the total omentectomy. Subtotal, when you talk about subtotal, the line will be here. The gastric arcade will be preserved. So that is known as a subtotal omentectomy. So you generally do at least an infracoelic. So here, when that area is removed, that is known as your infracoelic. Above the colon, when you do, that's known as a total or a subtotal omentectomy, depending on whether you remove the gastric arcade or you leave it in place. So based on that, how is what you will classify the various types of omentectomy. So you will do a omentectomy also, and infracoelic is the very minimum. Then other than that, what you do, you also do the node dissections. So what are the dissections that you do? You do the pelvic node dissection and the para-aortic nodal dissection, the pelvic and the para-aortic nodal dissections. This para-aortic, the minimum should be till the level of the IMA. Conventional is till the level of the renal vessels. Till the level of the renal vessels is going to be the conventional para-aortic nodal dissection. In ovary, at least till the level of IMA. Okay, at least if they have not mentioned the level, it means it is still renal vessels. If they have done an limited para-aortic or something like that, if you say, or minimal para-aortic dissection, then it has to be at least at the level of the inferior mesenteric artery. Now, why do you talk about the renal vessels? Because that is the area where your vessels are going to join. This is where your infundibulopelvic ligaments will go and drain near the IVC. So that is where the ovarian vessels will also take origin, and that is the reason you have to go till the renal vessels and you have to remove it. That is why the entire thing is taken as a packet. Now, is there any advantage of doing a lymphadenectomy? There was one study called as the LION study, which showed that lymphadenectomy in ovarian neoplasm. LION stands for lymphadenectomy in ovarian neoplasm. This study showed that there is no benefit in node-negative patients for doing the lymphadenectomy, as far as no OS benefit was there. But still, if you talk about oncologists, we tend to prefer to do this. It is not for survival that we are doing this. Let's say a patient undergoes this entire staging and node dissection is not done, then by default, you have to go for chemotherapy. By default, the patient has to get chemotherapy. On the other hand, if you have done the node dissection and it is N0 disease, suppose it is stage 1A or 1B, grade 1 or grade 2, then you can avoid chemotherapy. Now, people may think, what is the big deal in giving chemo? But chemo has got its own set of complications. So, if you can avoid chemotherapy, what are the things where you can avoid chemotherapy in carcinoma ovary? Stage 1A, stage 1B, grade 1 or grade 2. You can, if proper staging like this is done, meaning what? DAH, BSO, meaning the ovarian mass, and the other one. So, DAH, BSO, cytology, you have done at least an infracoelic omentectomy, then you have done peritoneal biopsies, then you have done your pelvic and para-aortic nodal dissections, and all of this confirms that it is a stage 1A or 1B, grade 1 or grade 2. Basically, it is confined to the ovarian mass. There is no rupture of the capsule. There is no capsular deposits. There is no intraoperative or this one. The cytology is negative. Everything being satisfactory, then you can avoid chemotherapy. You can avoid chemotherapy. So as a corollary to this fact, so what do you mean by this? Then you talk about grade 3 cancers. So when you talk about when you will need to give chemotherapy, so the role of chemotherapy in ovarian cancers. So when you look at the role of chemotherapy in ovarian cancers, this was established by the initial trial, which was known as the ICON and the ACTION trials. ICON and the ACTION trials. These were the ICON 1, it is known as ICON and the ACTION trials. So these were the first trials that were done as far as ovarian cancer is concerned. Now, these two established the role of adjuvant chemotherapy. The initial agent which was used was cisplatin, actually. Okay, so cisplatin, and actually, I believe it was adriamycin, if I'm not wrong. So the adriamycin, it is still used in some of the centers. Cisplatin adriamycin was the drug which was used initially. Later on, there were other trials that showed that cisplatin is replaced by carboplatin, which showed a much better safety profile. The efficacy is going to be the same, but the safety profile was better by using your carboplatin. So carboplatin was substituted, and again, it was the icon 3, if I'm not wrong, which showed that there is a benefit of using taxanes. So that is why paclitaxel came into vogue. So the combination of carboplatin plus paclitaxel is the current doublet chemotherapy standard of care. So doublet chemotherapy, whenever we talk about in ovarian cancer, we are talking about your uh, carboplatin plus paclitaxel. Carboplatin plus paclitaxel. That is going to be the treatment of choice in today's world. And minimum is 6 cycles. Usually you will give 6 cycles. There are some very early cases where you can do 3 cycles in stage 1. When we talk about 1C, when it's a grade 3 cancer sometimes, and all this, 3 cycles is equal to 6 cycles. This was, I think, the ICON 2 trial. So based on that, some people go for a minimum of 3 cycles if there is a very small indication for giving chemotherapy. So then they will go for this kind of profile. So essentially, the ICON trials, whenever you see the name ICON trials establish the role of chemo in ovarian cancer. The role of chemo in ovarian cancer was established by the ICON trials, and there are some 6 or 7 trials. I'll try to discuss them. I've already discussed in the app already, but anyway, so I'll try, if there is something, we'll discuss that as well. Now, HIPEC, as we all know, stands for hyperthermic intraperitoneal chemotherapy. The role of HIPEC has been proven beyond doubt by the that study, which showed that there is definitely good evidence of using HIPEC. So, but that was proven only in one setting, which is going to be your interval cytoreductive surgery setting. It has been proven only in the interval cytoreduction surgery setting. In primary, the role is not proven. Now, why this came is there are a lot of trials that have been used in IP chemotherapy. Normothermic intraperitoneal chemotherapy. Now, normothermic intraperitoneal chemotherapy clearly showed that intraperitoneal chemotherapy is going to be more beneficial. So when HIPEC was combined as an intraperitoneal chemotherapy at the time of surgery by the OB HIPEC trial by Vandriel et al., that clearly showed that there is a benefit of using it, but it was shown to be beneficial. The Vandriel trial, which was the first randomized trial that came, showed the benefit in your interval cytoreductive surgery as the OB HIPEC trial. On the other hand, there was another Korean trial called as the Lim et al. Trial by Lim et al. This was done both in the primary debulking setting or primary debulking surgery and in the interval debulking surgery setting. In these settings, it was again found to be beneficial only in the interval debulking setting. So that again clearly showed that there is an improvement in using HIPEC. So patients who are optimally debulked, so whenever you are using this, then there is a definite benefit of getting this one. So the overall survival was improved by around 12 months. This is a huge number. Now, whenever we talk about most of the drugs, the improvement in survival is going to be 2 to 3 months, and it is usually a progression-free survival improvement. This is what we get for most of the drugs currently, even molecular targeted therapy, everything which you take, there is an improvement in progression-free survival by 2 to 3 months. Imagine you're getting an improvement in overall survival by up to 12 months by doing this HIPEC. And again, if you look at the percentage, again, there is a 10% improvement in the numbers in overall survival. So the number of months is around 12 months. The number of percentage points is going to be 10 percentage points. This was shown by the Vandriel et al. OV HIPEC trial. Now, intraperitoneal chemotherapy is also useful. So a combination of intraperitoneal and IV chemotherapy is actually useful. So this was shown by the GOG 172 trial by Armstrong et al. The Armstrong trial was the strongest trial that proved the benefit of intraperitoneal chemotherapy. Remember, see how much of a proportion of survival, the p-value is also significant. But unfortunately, many medical oncologists do not, favor, because it is a little cumbersome to give. It has got its own set of complications. So many people do not want to give. They just want to give the traditional chemotherapy that, essentially is going to be only your IV line of chemotherapy. And, now targeted therapies are there, other things are there. So they feel the role of IP chemo is declining. Not many people give it. I still strongly feel that giving IP chemotherapy actually helps the patient achieve it. So Armstrong trial, GOG 172 was the trial. So GOG 112, 172, 148, so many trials were there. All of them showed the benefit of IP chemo. The strongest trial was the Armstrong trial, GOG 172, that showed the benefit. So that I feel should be the way to go. If not, then at the time of surgery, you can give the intraperitoneal chemotherapy as well. Right. Now, this was a similar thing. When you compare how is the way you have to treat an ovarian cancer, whether you have to do a primary debulking surgery initially itself, or you do something called as an interval debulking surgery. Now, this was a controversy. If you take up the US, till today, people prefer to go for only primary debulking surgery. In the US, still, the preferred modality is going to be a primary debulking surgery. So, interval debulking surgery as a modality came by the URTC trial. Okay, so the URTC trial was the first trial that showed the benefit, or rather, that giving neoadjuvant chemotherapy will downstage the disease and allow performance of interval debulking surgery. So this was the trial by URTC, which was the first trial, and it was again with National Cancer Institute was also there as part of the trial. It was a multi-centric trial, reasonably conducted. There was a lot of criticism of the trial also, mind you, but that is the time when the Scorpion trial was later published. Both of them showed that NACT and PDS, the efficacy is the same. Okay, they have got the same efficacy in terms of overall survival or progression-free survival or disease-free survival. Everything is all going to be the same, but the toxicity is going to be much better. The toxicity is going to be the same. If you look at it, the PFS, the OS, everything, there is no difference between giving NACT vis-a-vis giving this one. But if you look at the complications, that is going to be very different. If you look at the major events, there is a significant improvement. Patients with major complications, that is significantly better with the NACT arm. So now, if you look at it in India, many patients routinely get this neoadjuvant chemotherapy. I'll put it this way. Practically, if you have a patient who is poorly perfused, who is not in the best of general conditions, who may not tolerate chemo, not tolerate your initial, proper debulking surgery where you remove completely and you want to do achieving an R0 resection, that kind of thing, the patient won't tolerate initially, then it is better to go for just a biopsy, either image-guided biopsy or this one. That may be a question. How will you do your, interval cytoreductive surgery? So the thing is, usually this is a patient who will come with your momental mets and all that, or peritoneal disease will be there. So when all of this is there, look at the performance status of the patient first. If they have said that the performance station is poor, usually the question will come something like the poor performance status, or they might have said ECOG2, something like that will be there in the question indicating the performance status is not great. So when you have this, then what is the way you will deal with this patient? Usual thing you will do is something called as an image guided biopsy. That will be the first step here. So once you have done your initial imaging workup, you have done your CA125, all this you have done, the staging workup and everything is done, then you go for an image guided biopsy to establish the diagnosis. And once that is done, then you go for neoadjuvant chemotherapy. Next question is, how many cycles of neoadjuvant chemotherapy? Usual answer is 3. If 3 is given, that is going to be the answer. Otherwise, it may be 3 to 4. If it is not given, then it is 3 to 4. That is the standard. You don't go full and you don't give the 6 cycles. Currently, what is preferable is to go for neoadjuvant chemotherapy, usually 3 cycles. So you go for NACT 3 cycles, then you will do surgery. Now, this surgery, what you do is known as your interval cytoreduction surgery. Now, when you do it in the post-NACT setting, here you don't call it as a staging laparotomy. Remember, my friends, the first time when you're doing it, you call it as a staging laparotomy because you are doing the staging, you're establishing a surgical stage. Here, when you're doing, you already have established as at least stage 3 disease in most scenarios. You've got omental metastasis, which are proven by a biopsy, or anywhere in the upper abdomen, you've got metastasis. It is a stage 3 disease that you have proven. So once you have done that, the stage is already over. So here, what you're doing is a cytoreductive surgery. So what is the aim of cytoreductive surgery? CC0 is the aim of resection. So here there are some terms which are used again. So what is optimal? What is maximal cytoreduction? And what is suboptimal cytoreduction? So anything where what you mean by suboptimal is greater than 1 centimeter nodule. Any nodule greater than 1 centimeter if it is present, even a single nodule more than 1 centimeter is present, that is a suboptimal cytoreduction. Okay, so Is there a role for HIPEC in suboptimal cytoreduction? No. HIPEC is something which will be usually used in scenarios like CC0 and CC1. So what do you mean by the CC? There is another slide that is coming up. I'll show you that. But in essence, CC0 is no visible disease, and CC1 is less than 2.5 millimeter is the deposit. 2.5 millimeter is the deposit. Now, optimal cytoreduction is when you have less than 1 centimeter as the size of the maximum individual tumor deposit. So what do you mean by this? Let's say there are 100 nodules scattered throughout the peritoneum, but all of them are less than 1 centimeter in size. Then it is still an optimal cytoreduction. On the other hand, you have a single nodule which is 2 centimeters in size or 1.5 centimeters in size. Then you call it as a suboptimal cytoreduction. It may seem paradoxical, but that is the way it works. The reason is because chemotherapy is supposed to act better whenever there are less than or equal to 1 centimeter of nodules. It can penetrate and it can downstage the disease. That is the reason why you have to have an optimal cytoreduction. So this definition of optimal again has been changing over time. So Bristow et al. Started this initially. So for each 1 centimeter reduction, they said there is a 25% improvement overall in the survival that will happen. So something similar. So optimal initially started with 2 centimeters. So the maximum size of the deposit should be less than or equal to 2 centimeters. That is how it started. Then they made it less than or equal to 1.5. Then it became less than or equal to 1. Then less than or equal to 0.5. And currently it stands at maximal cytoreduction. Currently the term which is preferred is maximal cytoreduction, where you're essentially looking to clear all the disease. You're essentially looking to clear all the disease which is going to be found. And once you have a maximal cytoreduction, which is no visible disease, this is the same thing as saying CC0. Okay, so when you have CC0 or CC1, you can plan for HIPEC. Okay, so primary cytoreduction is out, suboptimal is out, interval is where there is a clear survival rate of 50% or more, which is proven. Secondary cytoreduction, what do you mean by this term? Secondary cytoreductive surgery. What do you mean by the term? Secondary cytoreduction surgery. So in secondary cytoreduction, what you have is in a patient who has been initially treated by, for either by primary staging or by whatever, and the patient comes back with a recurrence. Patient comes back with a recurrence after a primary cytoreductive surgery has been done and primary chemotherapy, all that is completed. Initial treatment is basically complete. Patient comes back with a recurrence. At this time, before initiation of chemotherapy, whatever you plan as a surgery, cytoreductive surgery, that is known as a secondary cytoreductive surgery. There is an AGO criteria for doing that, Association of Gynecology criteria for doing that. So basically what they say is the initial effort should have been done by a gynecologist or a surgical oncologist. Okay, and it should have been a optimal cytoreduction initially, and ascites should be less than 500 ml. So these are all the criteria which are known as the AGO criteria. So when you have this AGO criteria is when this criteria is to ability to achieve secondary cytoreduction. If these criteria are going to be fulfilled, that is known as the AGO criteria. So AGO criteria is surgery optimal cytoreduction done by a gynec or a surgical oncologist initially. Ascite is less than 500 ml. So all these criteria should be there. It is known as the AGO criteria for saying that there is a high chance or ability to achieve your secondary cytoreduction. So in a recurrent setting, whenever you're doing, that is known as your secondary cytoreductive surgery. Okay. So this is as far as the thing is concerned. And so the Scorpion trial is another trial which showed the benefit of giving neoadjuvant chemotherapy, where the survival is the same whether you do primary or neoadjuvant chemotherapy and then doing the interval debulking surgery, but the complications are much less. Usually what happens, tumors start shrinking, so the extent of resection comes down. You take out only the disease which was just looking as the remnant. You don't go and remove all the disease. So in terms of survival, though both are the same, what they say is the primary debulking surgery has got a lot more morbidity. On the other hand, the secondary debulking surgery, the morbidity is going to be much, much less. Now, let's go on to the next thing, which is going to be your histopathological diagram. So I have showed it to you multiple times in various things. So this one looks like a keratin pearl. It may be confused with a keratin pearl, but this is your sum of body with your inner body, you can see one central thing, you can see one central necrotic area kind of thing will be there. So that is your some or more bodies. That is how you will differentiate from a keratin pearl. All this you can see that there will be a central body which will be there. If you look closely enough, there will be a central body which is the central kernel of calcification. This is a central kernel of calcification which will happen, and surrounding that multiple world appearances will be there. Now these some or more bodies are classically seen in all your serous papillary tumors. Serous papillary tumors. So you can see it serous and papillary. So serous papillary ovarian carcinoma. Of course, we know about the papillary thyroid cancer. It is also seen in meningiomas. It is also seen in meningiomas. So any of these may be given in the differential diagnosis. So papillary serous, it may be papillary thyroid, or it may be meningioma. All of these you will get the some or more bodies which will be there. So there are a lot of bodies which will be there. Again, I have discussed in the videos that you would have seen. So you would have talked about the Schiller dual bodies. You would have talked about the coffee bean nucleus in your Karl Exner antibodies, which will be in granulosa cell tumors. You will have it. Schiller dual, of course, occurs in your yolk sac tumors. So like this, there are a lot of bodies which will be there. So look at it and then find out. You can usually make out, these histological diagrams will be very, very precise and clear. There will be no confusion usually. It will be very, very clear, and there will be a clue. So these are easy questions in the sense that if you just know the features, then you can answer. Most of these questions will be pretty easy to answer if you know what is the thing that you are looking for. And today's session I'm closing with this. Tomorrow or day after we'll have another session. We'll have a marathon session that will be probably the last session before your upcoming exams. I'm not sure whether I should plan a session on Friday or not. Thursday there will be a session 100%. We'll be having a marathon session. We'll be going ahead and we'll be doing one good chunk of discussion, not just on these questions, plus we'll be discussing other areas from which high yield topics are going to come. So that is something that I'll be discussing either tomorrow or day after, or if possible on both the days as well. I'll be updating you. 2 sessions will be there with all the high yield topics that we'll be doing before the exams, covering it up. So all the best, my friends. Today I've just tried to cover a bit of gynec oncology alone, and the rest of it we'll take it up in the coming 2 sessions. Thank you, my friends.